Hello, everyone. Thank you for joining today's webinar, Mitigating the Rise of Self-Insured Employer Healthcare Costs for Chronic Populations, the Impact of Pandemic Deferred Care. This webinar is sponsored by Abacus Health Solutions. Abacus Health Solutions is a pioneer in the behaviorally focused disease management field. Its approach is simple. Attack the high-cost drivers with precision-focused interventions proven to improve health, reduce hospitalizations, and lower cost. Utilizing the latest in healthcare technologies, Abacus's programs for diabetes and hypertension are built to foster high rates of adoption, drive members to providers, leverage remote monitoring technologies, and align with healthcare goals of quality and outcomes, resulting in healthier, less costly, more productive employees. I'm Sean Edwards from World Congress. I'll be introducing our webinar today. Just a couple of quick announcements before we start. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Q&A feature that you see at the bottom of your screen. We'll answer all questions that we have time to address during our program today. Also, please note the webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. I'd like to introduce our speakers for today. Dr. David Ahern is a co-founder and senior scientist at Abacus Health Solutions, and Nora Costa is the vice president of rewards at Mapfre Insurance, USA. And without further ado, I'd like to turn things over to David to get us started.
Thank you, Sean. We really appreciate the opportunity to present to you today on this topic, and particularly focusing on the impact of the pandemic in terms of both deferral of care and delaying care as a consequence in terms of cost for employers. So I'm a behavioral scientist and researcher, and as John mentioned, senior scientist for Abacus Health Solutions. I also have an appointment at Brigham and Women's Hospital and Harvard Medical School and direct a digital behavioral health informatics program there. So I've been working at the intersection of healthcare and technology for my entire career. I think we're in a particularly important time with respect to healthcare and the transformation of healthcare, which has really been accelerated in many ways by the pandemic. Our agenda today will focus on the reduction in care services that we've observed as a result of the pandemic over the last year and a half will likely lead to a dramatic increase in costs, and we'll kind of provide some evidence that suggests that that's going to be the case. But we're going to highlight the utilization of telehealth and telemedicine as opportunities to keep patients connected to care and on track, and really has helped enable virtual care. We'll then talk about the Abacus Diabetes Care Rewards Program, and then my colleague Nora Costa will talk about the Mapfre experience, and we'll provide other real-world case examples. It's no surprise to any of you, I'm sure, that the COVID-19 pandemic has really produced a decline in the use of healthcare services. And as this graph shows, in 2020, from January through November, there was a particular decline, particularly in the months from March through June, in the use of healthcare services and the spending associated with that. Although there's been a recovery as the year went on, and we've continued to see a recovery, that significant decline in the use of services would produce lower costs for the health plan. But unfortunately, we think that that brief change in the cost trend may be misleading in terms of what ultimately are the total costs associated both with the pandemic, the impact of the pandemic itself, and the effects of the pandemic on deferral or delayed care. And you can see hospital care and physician and clinical care services, although they had recovered by the end of the year, were still lower overall and had a significant drop, with dental services having the greatest decline during that 3 or 4 month period. Another factor that emerged with the COVID-19 pandemic is the really spotlight that was put on what has been well known, but has become even more of an issue of the structural inequities in healthcare in terms of the impact that the pandemic has had on deaths associated with COVID-19, particularly for persons of color. You can see in this slide, it's significantly higher for those persons of color relative to the Caucasian population. And it really does pose significant challenges for us in how we address these disparities going forward. And I want to give you an example of a paper that was published in Science by Dr. Ned Sharpless, who is the director of the National Cancer Institute. So the graph on the left shows the projection in what would be expected to be excess deaths from colorectal and breast cancer from 2020 to 2030 related to delays in screenings or deferral in care, that it's estimated that 10,000 additional deaths would occur over the next decade as a consequence of that, those delays in screenings and standards of care for cancer. We also know from prior research, and it's an important element in our program for diabetes management, is that people that have an ongoing relationship, meaningful relationship with their primary care provider have lower costs 1/3 less. And we know as a result of the pandemic, there's been a decline in visits to providers, particularly primary care providers, although, as mentioned earlier, the telehealth and telemedicine platform approach and virtual care has helped fill some of that gap. But nevertheless, we still have a concern about delays or deferral in care. So we're going to ask you a series of questions during this webinar. So the first question is, what is the average total healthcare cost per member with diabetes per year? So there are 4 options: $5,500, $13,700, or $16,750. So let me let you have a moment to answer this question. So the responses indicate that the most common was $13,700, which was 52%, and then $16,750. The actual correct answer is $16,750. And it may be surprising to some of you that those costs have continued to rise from year to year. And it really relates to the complexity of diabetes as an illness. And we'll be talking more about that as we go forward. So in terms of the data, the evidence about the impact of the pandemic, Quest Diagnostics published an article recently in Population Health that demonstrated the impact that 3 in 5 adults had avoided or delayed in-person healthcare during the pandemic in its intensity. 1 in 3 Americans with a chronic condition say their condition has actually worsened during that time. And 1 in 5 Americans had skipped or delayed blood work or lab testing. So this speaks to what I talked about earlier with cancer, and also we're particularly concerned about in diabetes. So the ability to stay connected to members with chronic illness is really an important part of optimal management. So we're now going to move to providing you with an overview of the Abacus Diabetes program. It's a patented program which is based on a behavioral science model to engage members in the preventative care standards established by the American Diabetes Association. And we support team members and their covered dependents with diabetes on our employer health plan clients. The target behaviors that we focus on provider engagement. So as mentioned earlier, we feel very strongly about the importance of maintaining an ongoing, meaningful relationship with your provider or with the primary care provider team. And then we provide telehealth support, which was particularly helpful during this pandemic, as noted, in keeping patients connected. And we use as an important part of our process behavior contingent incentives. And I'll talk more about that. The target behaviors that the program focuses on are those evidence-based American Diabetes Association care standards. And our goal is to identify where there are gaps in these standards of care for members with diabetes, for our clients, and we address them, as you'll hear more, in the way in which the program is structured and the incentives that we provide. So the key areas are eye exam, foot exam annually, lipid panel annually, annual urine protein testing, and twice yearly HbA1c as sort of the basic target behaviors that we focus on. And increasing those adherence to standards is proven to reduce hospitalizations. And I would make the point here, it isn't just achieving these goals at one point in time, it's the ongoing adherence to these standards over time that's really critical, and why we think the program has the impact it has, because it maintains that connection and support for these activities. One of the key components of the Diabetes Care Rewards Program is the development of a personalized diabetes health action plan, or what we call the DHAP, which is more than digital or traditional health coaching. It really leverages behavioral science, motivational interviewing, identifying barriers to adherence to medications for diabetes care and other comorbid conditions, and to the adherence to the care standards we just talked about. And it really does focus on care coordination. So we really enable the member to share their experience with the DHAP process and the goals of that with their provider. And then we also highlight where there are other complicating conditions where we often see that comorbidity, as indicated in the, as you'll see in the frequent comorbidity that occurs with diabetes. So our next question, what percentage of members with diabetes have one or more other chronic health conditions? 25%, 52%, 68%, or 87%? So we'll give you a moment to answer this question. Great. So 68% thought it was, 48% thought it was 68% have a comorbidity. 35% thought it was 87%. It actually turns out to be 87%. Again, it may be surprising to a number of you that diabetes has with it often other comorbid conditions. And this would include behavioral health, hypertension. There's a host of pretty common comorbidities that occur with diabetes, particularly as the condition continues over time, and it is an illness often that goes on for years, if not lifetime, for many patients. And so it is indeed 87%. Another key service that the Diabetes Care Rewards Program provides is medication therapy management. And for some of you on the call today, this may be a new term, or MTM, as it's called. But this is a service that's provided by clinical pharmacists that are trained in optimizing medications for chronic illness, in particular for diabetes. And it really aims to improve outcomes by helping patients understand what their medications are designed to do, why they're taking them, and often it's many medications when you look at the comorbidities, as we mentioned, that's pretty common, and how to maintain adherence over time. And also look for where there may be more meds that are necessary. So the clinical pharmacist we found has really developed an expertise that's particularly helpful here in optimizing medication therapy management. And I mentioned earlier about the behavior contingent incentives. So here we found that, and we've worked with a variety of different kinds of incentive approaches, but the one that has been particularly impactful is when members receive a reduction to zero or a reduction of their copayment or waiver of copayments on anti-diabetic medications and supplies when they're adherent to those care standards. And so we're able to track that over time. And what's pretty exciting is the ability to provide that zero copayment waiver at the point of sale at the pharmacy through our back-end data engine that allows for real-time adjudication of the claim, or processing of the claim result with the status in the program. And so we literally do this every day, where we look where members stand in terms of their adherence to the incentives. And if somebody falls out of adherence, we outreach to them and try to bring them back into adherence. But the copay waiver incentive can be turned off and on as a consequence. That is the patented process that we've developed. And these incentives are proven to drive high engagement. They increase adherence to the medications, and they also tend to attract high-risk members, which is where there are often a lot of costs because of the complexity of diabetes and the comorbidities that are common with high-risk members, and where they're taking many different kinds of medications. Another component, and we see this is increasing over the last several years, is the capacity for remote monitoring. So we've done a good bit of research in this space around the use of remote monitoring technology and devices. And Abacus has the ability to connect multiple devices across different formularies to really meet the needs of the member where they are with respect to the device they're using, the technology that they may be familiar with, but also offering them the capacity to use a device that we provide through a collaboration, both for remote blood glucose monitoring and remote blood pressure monitoring. And we can offer additional incentives for that. So it's really based on the clinical need of each patient. We don't necessarily believe that every patient needs to do remote monitoring and control with us or with the provider. We do believe blood glucose monitoring is critical. But in this particular case, we try to identify those members at particularly higher risk, where the benefits would be accrued if they do remote monitoring, share their data with both Abacus and their physicians. And we also are able to identify those members where they may have difficulty in control. And I've sort of referenced the Abacus engagement process. It's really a personalized messaging platform. So we use the biometrics for those in remote monitoring, the screenings and exams, the diabetes health action plan, and then we receive medical and pharmacy claims data from our clients. So we're able to really, from that combined data set and data warehouse, do tailored messaging where we can outreach to members if they're not monitoring or if they have an exam or lab coming due. And then we really try to reinforce when they stay engaged and try to maintain engagement over time. You sort of mentioned this risk identification and stratification. So part of what Abacus has developed is a machine learning and artificial intelligence capacity using the data warehouse that I've mentioned. We can identify member risk and we can identify those that may be at greatest risk for either falling out of adherence or at risk for hospitalization as a consequence of more complexity of their diabetes. And we've had some degree of success in identifying those members with potential for hospitalization, but more proactively identifying them, engaging them. To just review, Abacus's clientele include large self-insured employers across a number of sectors. We have a health care sector, a manufacturing sector. We work with municipalities that include the governance of the towns and cities, as well as educational groups, Taft-Hartley and union-based groups. We've had hundreds of organizations across the country, across a variety of industries. And we launched our first Diabetes Care Rewards program in January of 2008 with our first self-insured employer. So we've had a lot of experience in working in this space and watched it evolve. And also, I think, like to believe we've contributed to sort of the improvement in health management for members with diabetes. So at this point, I'm going to turn over the webinar to my co-presenter, Nora Costa, who's Vice President of Awards for Mapfre USA. Take it away, Nora.
All right. Thank you. Thank you, David, very much. And welcome to all of my benefit colleagues around the country who've decided to join us today. So I hope you find this Mapfre specific information useful and helpful. Just a little bit about myself. I've been at it for a long time. I've worked my career in the compensation and benefits career path with a few left and right turns along the way. I'm responsible for compensation benefits, HR technology, payroll, global mobility, and immigration at Mapfre USA. So my experience has really been grown by a number of career portfolio experiences that I have had working in the Boston area in both not-for-profit and for-profit organizations. And so I bring some of my large employer and small employer experience to how we approach rewards design at Mapfre. We can move on next, David. So let me tell you a little bit about Mapfre. First of all, it's not Mapfre, as many of people I run into might say. Mapfre is actually a Spanish company, and Mapfre is a Spanish acronym that, although I know it, my Spanish is not that good, so I won't trouble you with what that actually stands for. As a global insurance company, we provide a variety of insurance services to over 30 million customers around the world. And Mapfre Group acquired the former Commerce Insurance Company a little over 10 years ago. And so within the US, Mapfre has really a foothold here in the Northeast and in 14 other states around the US. We're a relatively small organization. We're 2,200 employees, or at least small in my experience, where I've worked for organizations that have 250,000 plus employees. But through it all, what I would say is that Mapfre Group and the culture that it has infused across all of the countries is based in our founders' principles. And we were actually founded, or Mapfre was founded, from a charitable foundation and a care for people. And that care for people has translated itself into providing security products through our insurance companies around the world. And that care for our policyholders has translated into care for our employees, particularly here in the United States. And so with my about 4 years of experience here at Mapfre, I've been very pleased and happy to bring a number of new programs and to expand around our existing programs when it comes to benefit program design. So we'll go to the next slide. So when it comes to health and well-being at Mapfre, it's really even one step above that. When we think about our employees, we take a very employee-centric approach to the kinds of programs in the reward space that we're building. We recognize the fact that really our employees are our most valuable resource. That's not unique to Mapfre. I'm sure every benefits colleague on the phone right now on this webinar is saying the same thing. So this isn't unique, but it is part of our day-to-day and our core approach to how we design our programs and how we interact with our vendor partners in the health, well-being, and financial space. So when I talk about whole person design, we of course want to create the kinds of programs that our employees and their dependents can rely upon for their physical and psychological health and well-being. But in the last few years, we've also expanded what well-being really means at Mapfre to include financial awareness and not just planning for retirement, but to plan for years like 2020, when many people lost their jobs. Luckily, not too many Mapfre, in fact, no Mapfre USA employees were impacted through employment because of COVID, but their family members were. And so the importance around financial wellness also comes with how to take care of yourself and how to plan for your medical expenses and those emergency expenses. And of course, we want to attract and retain employees here at Mapfre. We are in a unique little corner of Massachusetts. Our primary headquarters are in Webster, Massachusetts, which is a little bit south of Worcester. We also have corporate headquarters in California and Arizona, but the bulk of our employees are from central Massachusetts and are long-serviced individuals back from the commerce days. And so to add on to our whole employee experience, we're really encouraging people to look at different experiences for their career to really build out that career portfolio, which will give them the pride that we want to generate for being a Mapfre USA employee. And like everyone else on the phone today, I'm and my benefits team are constantly balancing cost, the rising cost of healthcare, with balancing our employee needs. We're a very paternalistic organization, and change comes with difficulty in our organization. But how we communicate and the why behind it and the new programs that we generate every year are kind of at the foundation of how we approach health and well-being at Mapfre. We can go to the next slide, David. So something new that we're trying this year is represented here on this slide when we talk about the Mapfre health integration. And so we held our first vendor integration summit about a month or so ago to be able to get a greater sense of collaboration with our multiple vendor partners. So between our medical plan provider, our dental and vision vendors, and our EAP and behavioral support vendors, we brought everyone together to talk about how can we communicate best with our employees. We have multiple access points when an employee has an issue or just wants to improve the quality of their life. And we wanted to ensure that our EAP provider understood what the health plan could provide. We wanted the folks at Abacus to understand about our new healthy eating plan that we're putting in place. So again, trying to find a way to funnel our employees and their dependents to the kind of care that they need when they need it. And so instead of working in the silos that exist from vendor to vendor, we're taking a new integrated approach this year and really starting to formulate a new approach to communications, which all for us will come together in our communications platform. You know, my goal for our employees and their dependents is if you have an issue, if you're trying to solve a problem related to your whole self, that you can come to one place and be able to type in the answer or select it from a drop-down box and be directed to all the multitude of plans and programs that we have. So I hope that the outcome of the vendor summit is going to bring us closer over the course of the coming years. So when it comes to the Abacus program, we have provided this benefit to our employees for a little over 8 years. We're very proud of our current engagement, where 50% of our members and their dependents with diabetes actually engage in the program. And of course, what I always ask Abacus is, how can we make it a higher number? I'd like it to be 100%, but unfortunately, you can't go and tap someone on the shoulder and ask them to participate. We just have a constant flow of information about our Good Health Gateway program, and Abacus really supports us through a constant flow of communication, not only to the members who have enrolled, but reaching out again to those who haven't taken advantage of the program yet, who have a diabetes diagnosis. The next couple slides are about our results, and why these results are important to us is because it shows a great trend in how the relationship between the Good Health Gateway program provided by Abacus and the length of our program, since we've been doing this since 2012, the kinds of improvements that have been made here are pretty dramatic. And the big highlight from this page is really the improvement in patients who have completed their A1C test in the last 12 months. When we started out, 47% of our diabetics were completing their A1C. That has improved to 89% right now. So the fact that we have turned the tables on communicating around the importance of preventative care is shown very much here in this slide. The other thing I would call out on this page is the, even within the last 12 months, with the avoidance of care that has occurred because of the pandemic, 97% of our population base has completed a long office visit with their primary care provider. Again, critical to meeting those standards of care for the diabetes population. The only other call out I'd make here is, as David spoke to the issue of comorbidity, some of these Mapfre gaps and risks that we have, some of the improvement can be shown here as well in things like the lipid profile test and our diabetics who are now taking advantage of statin drugs to try to deal with their cholesterol issues. So all of these things are starting to come together for our diabetes population. So when it comes to our Mapfre participants and the individuals who actually take advantage of Good Health Gateways, what is the fact that Abacus's approach to data analysis has been validated by or certified by the Validation Institute brings real credibility to the information that I'm sharing with you today. And so not only are more of our diabetics actually taking better care of themselves, but those who were at the greatest risk, those who had the poorest control, over the course of our relationship with this program, we have seen a dramatic increase. Over 18% of our members who had really poor control, we've seen tremendous improvement with that control, and substantially more of our diabetics actually following through with this very important A1C test. So when we look at our diabetic population as a whole, where of course we're interested always in managing our costs, our PMPM, we've looked back over our hospital admissions since the conception of the plan back in 2013, or 2012 rather. And overall, what the impact of the Abacus program has had for Mapfre employees with diabetes and their dependents is we've seen this dramatic drop in hospital admissions. So cost, so important. Every year, the executive committee at Mapfre asks me, so what's the medical trend looking like? And what are the illnesses of our population that we have, that we know are driving those costs? And so our total diabetes population, and when we look at our claims, diabetes continues to be our highest claims number among our population. What's dramatic here is that our 6-year claims trend is so much better and much lower than the overall national trends when it comes to increasing cost of care for diabetics. So the 27% versus 14.5% for the Mapfre population, that speaks to itself in terms of the impact that the Abacus program has had on us. So, gee, that went by so fast, all those slides. I think the most important thing is how the Mapfre participants feel about this program. every year when we go out and do our employee meetings, which I'm happy to know that they'll be in person again this year, the first thing that I get asked is, do we still have the Good Health Gateway program in place? You're not cutting that, right? No, we're not cutting that. So for the employees who are taking advantage of this, they are dramatically engaged in it. And it's a huge money saver for our population, but it helps us also reinforce to our employees how much we care about them, which is part of the Mapfre culture. And so the quote about it means so much to have support of our employer with such a great program, we take that very much to heart, because what our employees think about Mapfre and the benefits that we provide means a lot to us and is a measure that we look at the very highest level. So thanks very much, David. I'll let you take it away from here.
Thank you, Nora. That was a wonderful presentation of the health and well-being services of Mapfre, and we are just so pleased that we've been working together for 8 years, as you pointed out, and it really is impressive. And I wanted to just comment about sort of the company philosophy that you highlighted. Obviously, it comes through loud and clear in your summary of the approach. And I also would highlight the integration of services that we found with other clients is particularly valuable in looking at the whole person. And even though we are focused on the diabetes problem, we recognize it's really a whole person, and there are often many intersecting problems that have to be addressed. So thank you for that. And then one note, I wanted to thank you for clarifying or mentioning the Good Health Gateway, which I don't think I actually mentioned as the patient-facing platform for the member for the Abacus Diabetes Care Rewards program. And there's a portal, and there's an app, and so on. And we makes it easier for the member to understand that the Good Health Gateway is their gateway to health and well-being for their diabetes problem. So I want to, in addition to the Mapfre experience, I wanted to share another example of a manufacturing client from the Midwest. We have clients that are distributed throughout the United States, and this is a 3-year case study of a manufacturing client with a participation rate of about 40% of members with diabetes engaged in the program. And this is really important to highlight. 50% for Mapfre is just outstanding. It's pretty challenging to have members with diabetes adhere to all of the care guidelines and stay connected. It actually, when you do an analysis from the public data, it's more in the 12 to 15% of members with diabetes are actually doing all of the care activities that they need to do to maintain control of their diabetes. So getting a 40% in engagement over time is pretty impressive, and the 50% is outstanding. And to highlight this account, just as with Mapfre, the actual claims, clinical and financial outcomes are used in the projection of costs or the savings of costs, not just an estimate. And we typically look at the entire diabetes population, not just those members who are enrolled when we do our reporting to our clients. And the reason we do that is because there are often changes in the benefits from year to year for these populations. Members can move in and out of employment, and this sort of can account for that variation. And then we can make the comparison to the national trends as Nora pointed out when comparing the Mapfre experience with the national trends. But we will talk about a study we did that looked at enrolled versus unenrolled and how that turned out as well. So for this particular client, we see similar kinds of improvements, a pretty significant decrease in the number of members with A1Cs greater than 9. And an increase in the number of members with A1Cs at or below 7, which is sort of the cut point for HbA1c for the diabetes diagnosis. So clearly improvements on hemoglobin A1C changes, similar to what Mapfre experienced for the members with diabetes, both total medical and pharmacy claims on a PMPM basis. There was a 30%, nearly 30% lower cost for the diabetes population when comparing their baseline year to the average over the 3 program years. And as you saw in the previous slide with Mapfre, that the trend is really about a 4.5% increase per year, not a decrease. So when you see a decline, that's pretty compelling evidence of an impact. So we'll go to our final poll question at this point. Does a vendor being validated by an independent third party support you working with them? We'll give you a moment to answer this question. Okay, great. So the largest percentage indicated yes, 49%. That's really great news. 35% maybe, and 14% undecided. So there's some room for improvement there in terms of having the certification benefit for services by vendors, but this is quite encouraging. Thank you. So I mentioned that we've completed a what we call our book of business study in a scientific analysis that was done. And we are very excited about this paper being published in March in the American Journal of Managed Care, which involved over 3,000 members, including the members from Mapfre de-identified, all de-identified data, where we looked at it was a retrospective pre-post comparative study of members who were enrolled in the Diabetes Good Health Gateway program to a propensity score matched group that were unenrolled but eligible. And when we did that, we looked at the impact across the metrics that you've seen with Mapfre and our other client example in terms of gaps in care, hospital admissions, hospital days, some of the clinical outcomes, and ultimately the per member per month cost. And we see comparable kinds of results as we've seen in many of our reports to our individual clients. A much greater increase likelihood, nearly 20% increase likelihood of a physician visit over the next 12-month follow-up, which is really critical, again, back to that engagement with your primary care provider, your provider team. 38% lower all-cause hospital admissions. This is where if you can prevent hospitalizations for members with diabetes, you can really reduce the cost of care and the complications that obviously have produced that hospitalization. And then fewer hospital days often means that patients, when they are hospitalized, can be brought to a healthier state more quickly and not spend as much time in the hospital. And then we see a 20% decrease in the members with HbA1c greater than 9, and also a 30% increase in RX adherence. And this again speaks to the incentive approach that Abacus has, as we mentioned, where, if we have high-risk members who really need to take their diabetes medications, we want to reduce that barrier. And indeed, we see an increase in adherence as a consequence. And then finally, a 21% lower medical trend cost across this book of business for this study. And this, again, is available as an article that you can download, and we can also provide it to you from the American Journal of Managed Care, published in March of 2021. So with that, I do want to end with one slide, kind of bringing it back to the beginning discussion of the impact of the pandemic. It's obviously been a horrific experience for us in our society, both in terms of the pain and suffering of individuals with the disease and families that have impacted by it, and also the economic impact. But I believe there's a silver lining here. It's really highlighted the critical importance of maintaining connectivity and using technology where you can. Obviously, the utilization of telehealth and telemedicine really has been a bright spot, if you will, and what we've learned about how we can transform healthcare delivery so that it's more patient-centered and keep people connected, even in the context of a serious threat to health and well-being, such as the pandemic. And we need to increase our attention and efforts to address disparities in healthcare. Those gaps in care are there absolutely clearly and need to be addressed. And Abacus is committed to that and making sure that all members are eligible, who are eligible can benefit from the program. So with that, I'm going to turn the webinar back over to Sean, and we can open it up to any Q&A questions that may have come forward. Thank you.
Great, thank you. First question, David. Does the program support pre-diabetes or reversal?
You know, that's a great question, and the answer is yes, we absolutely do. You know, the diagnosis of diabetes often evolves over time. There's often testing that's done before a formal diagnosis is made. And often there are unfortunately, many members with diabetes who aren't yet diagnosed. So we do enroll members with pre-diabetes. They may often be on a low-dose metformin, and we engage them in the program and to the extent possible, prevent them from having more severe diabetes condition. And then on the reversal, absolutely, we do through the Diabetes Health Action Plan, through medication therapy management, through lifestyle modification and support, healthier eating, increasing physical activity. We have had members who have had their diabetes effectively reversed in terms of HbA1c levels. But we also believe it's important for to sustain those gains to maintain involvement in our program.
Got it. And are there any cases in which non-participants saw improvements based on the culture change within the company? And if so, what was the delta, if you have that data, from the participants to the non-participants?
You know, that's a great question too. And indeed, it's part why we do look at the whole diabetes population. And we have clients such as Mapfre, where they have employees that have been with them for a long time and family members that, you know, where they're not moving. And so we're really interested in the overall benefit, even to members who don't participate. We haven't actually done an investigation of those cohorts, but rather we identify and try to enroll members at any point, at any time that we can, at health fairs, with home communications at the home, with working with Mapfre and other accounts where they're willing to do employee emails to help engage members. So we do believe that there's a benefit, even for members who don't participate, but we haven't specifically studied that population.
Got it. And how many of your clients have on-site clinics which can be leveraged for care?
You know, that's a great question too. You know, I don't know if Mapfre does or not. Nora, does Mapfre offer?
No, we do not have an on-site clinic at this point.
We do have in our health care sector, we have been working, often we work with diabetes specialty clinics that the health system may be providing. So we've often done that and working with a pharmacy for health systems as well. In terms of coordinating the care. We do that for a number of large health systems that are our accounts. We do have accounts that have on-site clinics. One in particular that we've worked very closely with, where we have done webinars together, really highlighting the benefits of that kind of close collaboration where the client, as a very large employer, is interested in that vendor integration, very much like Mapfre. And one of the opportunities was for us to work closely with that on-site clinic, and we've done that. So yes, the answer is yes, we do, and we think that there's some real advantages there.
Okay. And was the 21% lower trend, was that only in the diabetic cohort, or was that for the entire population?
So when we took a look at it would be for the diabetes population that were enrolled. If we're talking about the study results, it would have been those that were enrolled, relative to those that were not enrolled in the study. So that change was in the study results. But when we look at, again, we look at the overall diabetes population for individual clients, then that percentage change is for the full diabetes population, whether they enroll in the program or not.
Okay. Nora, a question for you. Are there additional benefits you've seen from the program outside of the impact on clinical and financial measures?
Great question, and I would say yes. What we have seen, because we track our employee engagement through an employee net promoter score, or eNPS as we call it, what we've seen is that the type of program that we offer through Abacus, the fact that we are focused on diabetes, and we of course are planning to expand that to high blood pressure, hypertension as well, is that we're just seeing a natural uplift in what we call Mapfre Proud, which is our employees are proud to work for Mapfre and proud of the fact that we spend the time to understand what their underlying healthcare issues are, and that frankly we spend the money to provide these types of additional medical support programs for employees who are at the greatest risk. So we see it in our eNPS results. We see it in comments from employees specifically about the Abacus program, and then even more generally about how our overall medical plan and our total benefit package compares to some of the local competitors.
Got it. Thank you.
Sure.
David, another question. Could you explain the role of pharmacy consultation and its impact on care? Why pharmacists?
Again, another great question, and we're finding oftentimes that this seems relatively new, particularly to the employer health plan space, about the role of the clinical pharmacist in pharmacy. But as you know, the cost of medications have gone up, particularly for insulins and for diabetic medications. So it becomes an important consideration on the cost side. But what's really important is understanding the complexity of medication use, in that when you have multiple comorbid conditions, it's not uncommon for our members to have 6 or more medications being taken at a given time. And there are, at times, if there's some fragmentation in care for that member, they may be seeing a specialist and maybe the communication isn't as great with the primary care team. There may be polypharmacy, which means there may be 2 medicines that are being provided that are the same medicines, although maybe different brands. That's not uncommon. And it's up to a pharmacist to determine that and identify where one could be stopped, and identify where there are interactions among the medications, the side effects of these medications, and then so we talk about optimizing the medication regimen. That's what the pharmacist, clinical pharmacist does, and they're trained in these meds. And then we're also seeing this kind of rapid proliferation of new anti-diabetic medications, which hold great promise for reducing the impact of diabetes, but are both costly and have side effects that need to be managed. So we really think that medication therapy management is a core component of sort of the current optimal approach to diabetes care, in addition to the other kinds of services that we provide and other groups provide.
Okay. And how does driving members to their own doctors improve outcomes? I mean, shouldn't the health plans do that?
That's a great question too. And the health plans, I think, do try to do that. But it can be variable from health plan to health plan. And given that the way our program is structured, it's all designed around engaging the provider, because all of the care standards really are about making sure the providers is in the loop around communication. In our capacity to communicate on multi-channel and then use incentives to engage members and to keep them engaged with their provider is really key. And there's a challenge in primary care. I do a bit of this work in my work in the academic centers, where primary care is oftentimes struggles to maintain contact with patients, often has difficulty with those higher risk members. And so we often find from our provider community, folks who are working with members with diabetes who are in our program, they really appreciate what we're trying to do. And we actually work closely with a number of provider organizations nationally that have really seen the benefit of this kind of an approach to help them help their patients. Since the incentives now are more aligned to improve care for diabetes, for example, where the panel of diabetics, the better the care, the greater the return, the benefit financially, and the greater the health outcomes for their patients. So we find provider care is a critical piece of this, and one that's been an essential part of the Abacus model.
Got it. Was there any reduced efficacy during 2020 when communications were hampered by no face-to-face meetings? And if so, how much was the backslide, if applicable?
Great question. And yes, we were challenged. Abacus was challenged, as all organizations were challenged. I'm sure many of you on the call today recognize that those gaps in care were going to get greater because members were not necessarily going to go into the clinic or the hospital. They were being encouraged not to visit because of the risk involved. So it was appropriate for a period of time, but as you saw in some of the slides we shared about what the downstream effects could be of delayed care or deferral of care. Fortunately, this is again the bright spot of telehealth, telemedicine, which has always been in place, or has been in place for a long time, but has only been 1 or 2% of care visits and delivery of care. It went up dramatically. And the question will be, can we maintain that? Or, is there a hybrid model in the future for care delivery? And so what we did is we actually reached out to our colleagues at leading institutes for diabetes management and care and talked with them about the model that they were employing to try to increase, to maintain access. And they were creating a digital front door, creating a digital virtual, literally a virtual clinic model, so that their patients could still be connected to their care providers through a virtual platform. And so we adopted that. We certainly had been using that as a telehealth platform from day one with Abacus, but we also were more flexible and gave more opportunity for members to get connected with their providers than we otherwise would in terms of adherence. So we had to be flexible, and we knew that, and we did that, and we found that we were able to keep people connected, and they really appreciated it. And then again, we also found the additional benefits of having virtual services.
Got it. David, Nora, any final words of wisdom to impart on the audience as we wrap up?
I don't think so. Not for me, other than thanking everyone for joining us today in this conversation.
Yes, I would concur with Nora. Thank you very much. This was a great experience for us, and we really appreciate the opportunity to present. Thank you.
Great. Well, thank you both. And thank you to Abacus for making this session possible today. Thank you to the attendees for joining us. If you want any more information on the Validation Institute and the reports that were also referenced, please visit validationinstitute.com/validated-reports. That's going to do it for today. Just a reminder, folks, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. And to access additional webinars or get info on how your organization can speak or sponsor, you can visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.